Hello, I hope you guys are all doing well and staying awesome. So today, Max, Anna, and I will be presenting on the effects of hypothyroidism on pregnancy, and thus we also hope to make a bit of a connection between what we learned in the first block and what we are currently studying. So just to give you a quick overview of what is to come, first I'll explain the relationship between the hormones involved in pregnancy and the thyroid hormones. Then Max will present to you a research paper about the effects of hypothyroidism on pregnancy. And finally, Anna will explain a case study of a woman with hypothyroidism who is planning a pregnancy. So during a normal pregnancy, the mother's thyroid is stimulated, and this causes a 10 to 15% increase in the size of their thyroid gland. And this is mainly caused by the changes in the two hormones, HCG and estrogen. As we have learned, HCG is mainly produced by the placenta, and it's at its highest during the first trimester of pregnancy. The reasons for its effects on thyroid hormones is due to a structural similarity to TSH, and this is illustrated in the image on the right. So this allows it to bind to TSH receptors in the thyroid cell membrane, and as such it weakly stimulates the thyroid gland to produce more T3 and T4, and it also causes a decrease in serum TSH, as the graph represents. We also know that throughout pregnancy, estrogen levels increase, as we saw in the 2 slides prior. And this causes a 2 to 3-fold increase in thyroid binding globulin, mainly a few weeks after contraception. This can be seen in the red line in the graph here. This increase is caused by an increased synthesis of TBG by the liver and the prolongation of its half-life from 15 minutes to 3 days due to estrogen. And since most of the T3 and T4 that circulate throughout the body is bound to TBG, total T3 and T4 also increase, but there isn't any effect on free T3 and T4. So similar to levels of TBG, T3 and T4 increase rapidly at the beginning of pregnancy, but plateaus at the beginning of the second trimester at around a level of 30 to 100% of normal values, which is what you can see in the blue line of the graph here. During development, the fetal thyroid doesn't concentrate iodine to produce its own T3 and T4 until about 10 to 12 weeks. And the synthesis and secretion of T3 and T4, controlled by its own TSH, only starts from about 20 weeks. And so, because of this, the fetus relies heavily on the mother's thyroid hormone supply through the placenta. And so it's really important for the mother's thyroid hormone levels to be regulated well to reduce the risk of adverse effects on the pregnancy and the fetus. So since the thyroid hormones in pregnancy are highly interconnected, it would be important or crucial for people with thyroid abnormalities, such as hypothyroidism, to take this into account when they want to plan a pregnancy. And so Max will explain a bit more specifically about hypothyroidism and how it can affect a pregnancy.
So before we go into my part, I wanted to just discuss some vocabulary. So the first one is thyroid peroxidase antibody, or also known as TPO-AB. This is a marker for the presence of an autoimmune disorder, so they're usually found in your blood. Then the second one is folliculogenesis, which obviously, if you have studies for the test today, you would know this. But just a refresher, it's the maturation of ovarian follicles. Then the third one is apoptosis, if I'm pronouncing that correctly, which is a form of programmed cell death. And then the fourth is subfertility. And this was slightly mentioned in the guest lecture, but just a refresher. It was a delay in conception, so not necessarily infertility. You can conceive naturally, it just takes longer than usually. And then there is recurrent miscarriage, which was defined in the research paper as 2 or more, not necessarily consecutive miscarriages before 20 weeks of gestation, verified by pregnancy or test and or ultrasonography. And as you can see, the research paper is called The Influence of Thyroid Disorders on Adverse Pregnancy Outcomes by Rosa Vissenberg. But she made sure that the word hypothyroidism was very much explained, as in there are multiple types of hypothyroidism, and just referring it to as hypothyroidism technically incorrect. So first is the types of hypothyroidism. So first is overt hypothyroidism, which means a clear hypothyroidism, so an increased TSH and a decreased T4 level. And this is usually the hypothyroidism we talk about when we just say the word hypothyroidism. Then the second one, subclinical hypothyroidism, is an early form of hypothyroidism. So TSH levels are slightly elevated, but the thyroid hormones are within normal range. And then the third one, clinical hypothyroidism, is like subclinical hypothyroidism, but the symptoms range from mild, so range from subclinical hypothyroidism, which is a mild form of hypothyroidism, to very severe. And this very severe sort of outcomes is what is classified as clinical hypothyroidism. And the fourth is Hashimoto's disease. And Hashimoto's disease usually means that you have hypothyroidism with TPO antibodies, as the thyroid disease is an autoimmune disorder, and TPO antibodies kind of signify that the hypothyroidism comes from an autoimmune disorder. And Hashimoto's is also one of the most common forms of hypothyroidism. Okay, moving on. So, Vissenberg's research paper explores the relationship between hypothyroidism and pregnancy. In her research, she found that thyroid hormones are crucial for embryonic development for the first month of gestation and even before fertilization. This is due to the fact that thyroid hormone transporters and receptors are expressed in the ovary and early embryo. So in the ovaries, hypothyroidism disturbs folliculogenesis, and usually T3 together with FSH can help granulosa cells proliferate and inhibits their apoptosis. Thus, hypothyroidism, lower levels of T3, causes a disruption in ovulation and your menstrual cycle, so that the chance of becoming pregnant is lowered. Then secondly, research also found that hypothyroidism negatively affects spermatogenesis, and so sperm count and motility is lower than usual. Therefore, hypothyroidism is associated with lower fertilization rates. This also affects embryogenesis, and as we said, there are transporters and receptors also expressed in early embryos. Thyroid hormone transporters and receptors are also expressed in the endometrium, uterus, and placenta. However, the research paper stated that information is lacking to conclude that their function changes for better or for worse during hypothyroidism. And so, because of all these complications, hypothyroidism is closely correlated with unexplained subfertility and recurrent miscarriage. So there are some possible treatments that Vissenberg included in her research paper. So the first one was the administration of levothyroxine. The administration of levothyroxine was very helpful for clinical hypothyroidism, as it lowered the risk for miscarriage. And levothyroxine also helped for subclinical hypothyroidism, but with the subclinical, there wasn't exactly a pattern, so Vissenberg didn't conclude that this was a possible treatment for subclinical hypothyroidism. This is also why she suggested that prenatal screening for thyroid disease could be helpful. So prenatal screening allows the mother to know what's going to happen with the baby. And it's early enough as well, because Vissenberg also stated in the paper that women usually wait for their first screening from about 8 to 10 weeks of gestation, and this could already be possibly too late for the baby. And then a third one was IVF could sometimes be helpful, but then again, there was not exactly a relationship with this, and so she also didn't say that this could be a definite solution. But IVF, obviously, if you think about it, you are pumped with hormones to mature follicles, and then they are mixed in with sperm to be fertilized, and then they're injected back into the uterus. So this kind of skips the step in the ovary, as I talked about last time. So if you see, the ovary was also one of the things that was affected. And if you skip that step, there could obviously be a much higher chance of becoming pregnant. And it's also important to note that the thyroid function often starts changing in the first trimester because an increased need for thyroid hormone, because the baby's thyroid hormone is not fully developed nor works properly on their own for the first month. And now on the next slide, Anna is going to discuss a case study.
Around 2.5% of pregnancies are affected by maternal hypothyroidism. It generally delays the neurodevelopment of the fetus, and it can have many effects on the fetus itself, as well as later on in the child's life. This is why it is extremely important for women with known primary hypothyroidism to have their thyroid-stimulating hormone levels checked at least once per trimester, and they also generally require an additional dosage of levothyroxine. Our case study is about a woman who was diagnosed with primary hypothyroidism at the age of 23. And at the age of 33, she was taking a 0.112 milligram per day dosage of levothyroxine, and this dosage had been stable for at least 2 years now. She was wanting to get pregnant naturally, and so a plan was made, along with her doctor's help, to try and ensure a healthy and safe birth without worsening her hypothyroidism. Before pregnancy, she began taking folic acid around 2 months before the conception occurred, in the dosage of 1 milligram per day. And then 7 weeks before the planned conception, she measured her hormone levels and found that her level of thyroid stimulating hormone was 5.95 milliunits per litre. This is almost 2 times greater than the normal level it should be in the blood plasma. So she increased her dosage of levothyroxine to 0.116 milligrams per day. When the pregnancy was confirmed at home, she stopped taking the folic acid supplement and instead began taking prenatal multivitamins that had been requested by her doctor. These multivitamins contained iron, folic acid, and other vitamins and minerals. 8 weeks after her last menstrual period, her thyroid-stimulating hormone was rechecked and found to be elevated at 40.75 milliunits per litre. This is 8 times greater than the level in week 1. As well as this, her level of normal free thyroxine was found to be 12.6 picomoles per litre, so the dosage of levothyroxine she was receiving was increased. The dosage of levothyroxine was adjusted multiple times in response to her level of thyroid-stimulating hormone throughout her entire pregnancy. During week 37, labour was induced and she gave birth naturally to healthy twin boys. After the delivery, the mother did not receive any levothyroxine for the first week. After the first week, she continued with her therapy and received levothyroxine in a dosage of 0.175 milligrams per day. Her thyroid-stimulating hormone level was continuously monitored and checked, and eventually the dosage of levothyroxine was reduced to 0.125 milligrams per day, which caused the level of thyroid-stimulating hormone to stabilize.
So to conclude the presentation, there are some take-home messages that we want you to remember. So patients with hypothyroidism planning a pregnancy must implement a plan for the safety of the mother and child, as it is closely correlated with unexplained subfertility and recurrent miscarriage. As I briefly talked about in the research paper, this can be done through prenatal screening to see how it would affect your child. It is also important for a pregnant patient with hypothyroidism to continuously check the level of their thyroid-stimulating hormone throughout the pregnancy to see if it ever becomes a problem. Thirdly, although both prenatal multivitamins and levothyroxine were taken from the case study, the interaction between the two remains uncertain. And this was the end of our presentation. Thank you so much for listening. And this is the bibliography. We did do the bibliography. So yeah, that was the end of our presentation. Thank you for listening.